So with this, I'd like to introduce the next speaker, Dr. Anju, Anju Suresh, who's the head of Orbit and Oculoplasty Services, Chaitanya Eye Hospital, Kollam and Trivandrum.
Good morning, everybody. Good morning, everybody. Today we'll deal with biologics and orbital inflammation. So at the beginning, I should mention that we have not yet started using. We are just getting more and more information about the possible biologics that can be used. So biologics are considered in non-infectious, non-malignant inflammations of the orbit, like in thyroid eye disease, orbital inflammations due to rheumatological conditions, and non-specific orbital inflammations. So this was a 47-year-old patient with Graves' disease. On mycophenolate, he presented with loss of vision in the left eye. So you can see his MRI picture. There is increased size of all extraocular muscles. The optic nerve has lost its sinus curve and is stretched. So he is actually suffering from stretch optic neuropathy. And there is severe proptosis, increased orbital fat volume, etc. So he has to be treated with high dose IV methylprednisolone according to the ONTT protocol. But then after that, his proptosis is still there. His diplopia is still there, and his extraocular muscle movements are also affected. So what next? He can have either a surgical orbital decompression or a course of orbital radiotherapy, or he can have injection teprotumumab. So what is teprotumumab? As she mentioned earlier, it's a monoclonal antibody, and MU means that it is fully human. Teprotumumab is a monoclonal antibody directed against the insulin-like growth factor 1. It competitively inhibits the receptor so that IGF cannot bind to the receptor. And there are no biosimilars available. And on the market, it is available as Tepeza. So why was IGF-1 receptor considered in thyroid eye diseases? So clinical molecular studies have shown that IGF-1 receptor and the TSH receptor exist as a physical and a functional complex on the cell membrane. So they act together, and this is called receptor crosstalk. This means that if the IGF-1 receptor is stimulated, the TSH receptor also gets stimulated, and vice versa. If we inhibit the IGF-1 receptor, that also inhibits the TSHR receptor. So when stimulated, they act together. Their downstream pathways are actually different. IGF-1R is a protein kinase receptor, and TSH works by the G protein coupled receptor. So together they act synergistically to increase the production of hyaluronic acid and orbital fibroblast proliferation. And why teprotumumab in thyroid eye disease? Tepeza was actually developed for the treatment of metastatic solid organ tumors, but was found to be ineffective. However, studies in patients with thyroid eye disease, and the study was OPTIC and OPTIC-X. OPTIC, they studied 40 patients with thyroid eye disease, were given 8 injections of Tepeza, and the placebo group was given normal saline. 8 injections given over a period every 3 weeks for a period of 24 weeks. And at the end, the outcome studied was mainly proptosis. Other secondary outcome study were diplopia, extraocular movements, clinical activity scores, and the Graves orbitopathy, quality of life scores. So it showed marked improvement. All patients showed marked improvement in proptosis. That is up to 80%, 83% of the patients improved as compared to 10% of the placebo group. And then the patients in the placebo group were then given an 24-week course of Tepeza for the next 24 weeks and observed after 48 weeks. So that is the OPTIC-X study or the OPTIC extension study. So this is a phase 3 trial of the drug, and this was submitted and they got US FDA approval for first line medical treatment of TED in 2020. So this approval is for USA, but not yet in the European Union or UGOGO guidelines also. So how will you administer? The initial dose is 10 mg per kilogram. Why 10 mg? It is to see if the patient can tolerate the medication. Followed by 20 mg per kilogram, which is the actual correct dose. This is given every 3 weeks for 8 doses. Why a dose of 20 mg per kilogram? Because at that dose, 90% of the IGF receptors are blocked. So administration, it is available as 500 mg lyophilized powder in a vial that should be diluted with 10 ml sterile water, and this should be added to a 100 ml infusion of saline if the total dose is less than 1800. If it is more than 1800, you use 250 ml normal saline. So what are the adverse effects? Like the name suggests, it's an insulin-like substance, growth factor. So when you block that, you should expect hyperglycemia. So hyperglycemia is seen in 10% of the study population. It is also a growth factor. Therefore, when you block the growth factor, you block the growth in all cells all over the body. So it results in hair loss, weight loss, gastrointestinal problems, menstrual disturbances, nail breakage, etc. And of course, infusion reaction is always a possible adverse effect. So the unexpected side effect was hearing loss, which actually they didn't recognize initially, but later on individual case reports have come that hearing loss, often permanent, results from use of Tepeza. And the contraindications are inflammatory bowel disease. It can cause reactivation of ulcerative colitis, etc. Obviously, in an uncontrolled diabetic patient, it's difficult to use, and pre-existing hearing impairment. Because hearing loss is often permanent, before starting on Tepeza, you have to do a pure tone audiometry. In the middle of the treatment, you have to do a pure tone audiometry, and at the end of the treatment. Hearing impairment occurs more in older patients, more at higher frequencies, and is often permanent in those who already had pre-existing mild hearing impairment. If the patient cannot afford Tepeza, a second-line treatment that can be used for thyroid eye disease is tocilizumab, which is available as Actemra. So what is tocilizumab? Again, it is a monoclonal antibody, humanized monoclonal antibody, which means that the chance of infusion reaction is a little bit more than Tepeza. It is an interleukin-6 receptor, and biosimilars are also available. So what is interleukin-6? It is a part of the pro-inflammatory cytokine cascade present in the orbit in Graves' orbitopathy. It amplifies the T-cell mediated inflammation within the orbital tissues. So it was found that it is higher in patients with active disease of thyroid orbitopathy, and can act as a potential biomarker. So again, the IL-6 inhibitor attaches to the receptor on the cell membrane and blocks the action of IL-6. So this decreases the inflammation within the orbit, but it does not modify the disease process. Therefore, there is not much effect on proptosis or diplopia. However, it will improve the clinical activity scores. Dosage, it is given at 4 mg per kilogram IV every 4 weeks. And then you can increase to 8 mg per kilogram for the next 4 weeks, depending on the clinical response. It is given 800 mg per infusion IV, again diluted with normal saline. Subcutaneous form is also available. You get 0.9 ml of 162 mg of tocilizumab. And subcutaneous injections were developed to facilitate self-administration. So main adverse effect causes neutropenia. So the chance of activation of latent TB is more, chance of invasive fungal infections is more. And therefore, the main contraindication is an absolute neutrophil count less than 2000. And of course, infusion reaction. So this was a 50-year-old with non-specific orbital inflammation. You can see the slightly enlarged lateral rectus and the slightly enlarged lacrimal gland. He responded very well to IV systemic steroids. However, in a steroid intolerant or steroid resistant patient, as a third line option, second line is the use of immunosuppressives like methotrexate, etc. As a third line option, you can use rituximab. Again, biosimilars are also available. So rituximab acts on the CD20, is a protein present on the cell surface of B cells. So the Rituxan binds to the CD20 and forms a cap-like structure over the B cells, which makes it easily identifiable to the killer T cells and macrophages. And dosage, we follow the rheumatological protocol for orbital inflammation. That is 1000 mg IV infusion, day 1 and day 15. And you can follow it up if the response is not as advocate. So because it is a chimeric monoclonal antibody, you should pre-medicate with antihistamines, acetaminophen, 100 mg IV methylprednisolone, etc. and give as a very slow infusion. You start with 13 drops over 1 hour, then 26 drops the next hour, so over a period of 4 to 6 hours. And adverse effects, again immunosuppression. A special adverse effect is progressive multifocal leukoencephalopathy, which is a fatal disease with no known treatment, and also hepatitis B reactivation. So other agents under trial are the oral form of IGF-1 receptor monoclonal antibody, and we are trying to develop a TSH receptor blocking monoclonal antibody also. Two IGF receptor antibodies which have just finished their phase 3 trials are IB1311 and veligrotug, which is going to be available in 2027. So in the future, thyroid eye disease will probably be managed with a combination of a IGF receptor monoclonal antibody and a TSH receptor blocking monoclonal antibody, which will ultimately be the treatment protocol. Thank you.